Now, the patient's in the correct position for the preliminary ultrasound of the leg prior to cannulation. We have put sterile ultrasound gel in a large 60 ml syringe, and that makes it very easy for me in one movement to apply gel along the course of the vein. So we can dispense the gel very easily. We found that a very effective method of dispensing ultrasound gel during the procedure, and I would recommend this as a tip to any vascular specialists who are undertaking this. Put the ultrasound gel in a large dispenser. I'm very grateful to Ian Lomas of ProMed who helped me with this and shared this top tip. So we've got ultrasound gel on the leg. We're now going to place the probe on the leg and look at the vein that we're going to cannulate. And I'm going to just change some of the settings. And already we can see in the thigh, this is the mid-thigh of the leg. We're imaging the vein in transverse section. I like to see the vein as a circle on the screen. I know it's a vein because with light pressure it collapses. So that's not an artery, it's a vein, it's collapsible, so it's patent, it hasn't become occluded by clot. It's a very large vein. When I last measured it, it was over 12 millimeters. So he's got a very large, great saphenous vein in the mid-thigh, and I follow it down his leg. We're now at the knee level, and we can see that it's still very dilated. At this point here, just at the knee level, we see a tributary coming off and going superficial, and the great saphenous vein carries on down into the calf. So we here see the vein, and that's a point where I'm going to cannulate. So we're about 4 centimeters below the knee joint. A tributary has just come off. We could go further down, but it's not necessary. The vein is of normal caliber there, and further down the leg, the vein will be very close to the saphenous nerve, and it would be a risk of injury. So a convenient point to cannulate in transverse section is just below the knee, and I'm confirming that it's a vein. I like to cannulate in transverse section for several reasons. I can see the vein very accurately. I can see the surrounding structures, any nerves or important structures nearby, and I can perform the procedure with my left hand holding the ultrasound probe and my right hand holding the cannulating needle. So that's the vein we're going to treat, and that is the point in the leg where we're going to cannulate the vein. So I've chosen the point of access. I'm concentrating hard on the patient's leg, but the patient's not being ignored. Jane is at the top end, or by the patient's side, and she's chatting away in the background. You can't hear her, but she's chatting away to the patient, confirming that he's comfortable and monitoring the vital signs. So I've chosen my point, transverse section. I'm going to apply some local anaesthetic to the area where we're going to cannulate. I've got a small syringe of lidocaine. It's got a 30 gauge needle, so it's a very, very tiny needle. A little bit of a scratch, here we go. A little bit of a scratch. So we are putting a little so-called bleb of local anaesthetic at the proposed site of entry. We're raising a little bleb of local anaesthetic solution just underneath the skin, and that's at the midpoint of the ultrasound probe in transverse section. And on the ultrasound screen, if you could have a look, you can see that the vein is in the middle of the ultrasound picture. So we've got the vein in the middle of the ultrasound picture, and we put a bleb of local anaesthetic right in the middle of the width of the probe. So there you can see now, there's the gel on the leg, and there's a little bleb of local anaesthetic. We give that a few minutes to anaesthetise the leg, and then I'm going to make a small little nick in the skin with a 1 millimeter dermal punch, and that just makes a little entry point. It's a very tiny little 1 millimeter nick. I don't know if you can see that there. And then we're going to cannulate the vein with the this is a 14 gauge. No, this is a 16 gauge. We're going to cannulate the vein now with a 16 gauge cannula. That's the point. Reapply the ultrasound. Now I don't know if you can see what I'm doing here on the surface of the leg, and if you can see also on the screen, you can see the cannula coming right up against the vein. And as I advance the needle, you can see that it enters and punctures the vein. There is the tip of the cannula now in the center of the target vein. And what I'm doing at the moment is advancing the cannula and also moving the transducer. So it's a two-handed exercise. I move the transducer slightly up the leg to keep the tip of the needle in focus on there. And here we are, we've successfully cannulated the vein, and the patient has felt no discomfort, and we've confirmed that we're in the vein by the presence of a little bit of blood which has come back from the vein into the cannula. So we've successfully cannulated the vein now. I'm going to put the probe down, and we're going to now introduce the guide wire. This is a so-called Seldinger technique. We've got a guide wire here with a little introducer. The guide wire will be advanced gently up inside the vein, and then over this guide wire we will introduce the sheath. So here's the guide wire, we're ready to go. I'm going to withdraw the needle part. I'm going to apply a little bit of pressure beyond the cannula so that we don't get too much back bleeding. And then we introduce the guide wire into the vein. Very gently introduce it. Some people can feel a little sensation as we introduce the wire, but in most cases they don't feel anything at all. And in this case, the patient hasn't felt anything. So we've now got the cannula inside the vein, the guide wire inside the vein, and at this point we remove the cannula whilst leaving the guide wire in place. Some people feel a little sensation at this time. There we are. And we have successfully cannulated the vein. So we've got the guide wire inside the vein, and over that we can then introduce the catheter. As you can see, very little blood. This is not a procedure where we get a lot of blood, and it's also a procedure where there's very little discomfort. Now the next thing we do before we do anything else is we apply a little bit of tumescent local anaesthetic. So tumescent local anaesthetic is the anaesthetic solution we provide for pain relief. Tumescent local anaesthetic was invented by a dermatologist in California 30 years ago now, called Jeffrey Klein. And this tumescent local anaesthetic solution is sometimes called Klein solution, after Jeffrey Klein, who first formulated it. We use 1 litre of a bag of saline, and we'll show you that in a moment. 1 litre of a bag of normal saline. It's called normal saline because it's very close to the amount of saline that's normally in blood, concentration-wise. And to that litre of normal saline we add, or I add, 50 mils of 2% lidocaine, 10 mils of 8.4% bicarbonate solution, and 1 milligram of adrenaline. And that is the so-called tumescent local anaesthetic solution. So I've put some local anaesthetic solution around the cannula site. I'm now looking with the ultrasound, and I'm applying a little bit more tumescent to the vein and the guide wire inside it, so that when I insert the cannula, it is very comfortable for the patient. And as you can see on the screen, we've got a little dot, little white dot, which is the wire inside the vein, and I've also put quite a bit of local anaesthetic around, all under ultrasound guidance to make sure that when we introduce the cannula, it's very comfortable for the patient. So, having applied the local anaesthetic around the guide wire, we're now going to introduce the sheath for the laser. It's got a introducer portion, and then it's got the introducer sheath itself, all connected to some tubing and three-way tap if you wish to apply any medications or flush. So, we put the guide wire into the sheath, through the sheath. We make sure that the guide wire is out and that we make sure that isn't advanced and is introduced too far up the leg. And then we gently introduce the sheath over the guide wire. A slight rotatory action seems to help introduce the, and very gently introduce it. Sometimes patients feel a little sensation as we do that. Sometimes they feel nothing. And there we are. The introducer is through the skin, into the vein, and the guide wire has helped with that. That's why it's called a guide wire. Okay, having done that, we take the guide wire out, and we take the introducer of the sheath out. And then that allows us to very safely introduce the laser fibre. So that's how I cannulate the vein. It's an essential skill of all phlebology, all vein specialists, to be able to cannulate the vein under local anaesthetic. Essential points for me are that I do it in transverse section rather than longitudinal. Nothing against longitudinal. Transverse works better for me. I think it has a number of advantages. It can be performed as a single operator without the help of a technician. Left hand has the probe, right hand has the needle, and then we have placed our introducer and we're ready to do the procedure.